771 in Medic 6. You're seeing a 74-year-old male, shortness of breath.
Honey, my stomach hurts.
Many of the calls you respond to are for patients who have not suffered injury or trauma, but are experiencing signs and symptoms of disease. A thorough understanding of how the body works and what happens when it isn't working right will enable you to quickly identify signs, symptoms, and to deliver the best care possible.
She's right over here.
Hi, I'm Jay. I'm from the Paulsville Fire Department. What's your name?
Emily,
Emily, can we help you? What's wrong?
my side hurts.
Your side hurts. When did it start hurting, Emily?
It started about 3 days ago, and then I woke up this morning and it was worse. And
Medical assessments are pretty much the same as trauma as they get underway. However, in the focused history and physical exam part, that's where the real differentiation takes place. In trauma, we talk about the idea of it being a systematic approach to an unresponsive patient or even a specific type of injury, such as a cut finger. For medical, unresponsive, they pretty much get evaluated the same way we do for an unresponsive trauma patient or a multi-system patient. It's very thorough head to toe because the only way we can gather the information is by touching the patient and finding what we can find about them that way. Where it becomes more interesting for this is the patient who's conscious, alert, and oriented, able to give us information, who has a medical condition, and for us to be able to then just appropriately find the details and intervene with what we find.
Emily, this is Denise. She's going to take your blood pressure. Can you show me where it hurts, please? Right in there?
Well, in order for EMS providers to be able to adequately treat a patient who presents to them medically, first and foremost, they have to be able to assess that patient and determine what the problem is. They have to be able to be a detective. And for the medical patient, the thrust of it really takes place in the focused history and physical exam, and being able to differentiate between the sample history and the other information to make an informed decision about what the situation is with the patient and then what care needs to be provided to them.
So I'm going to have to ask you a few questions now. Are you under a doctor's care now?
no,
Did you have a bowel movement this morning?
yeah.
You did?
Sizing up the scene and performing a primary assessment is similar, regardless of whether it's trauma or medical. However, instead of the usual safety concerns at a motor vehicle accident, with medical patients you may find yourself dealing with very different challenges, such as the presence of weapons, pets, family disputes, or the involvement of alcohol or other drugs. Your assessment steps will also differ, depending on a responsive or unresponsive patient. This program focuses on the responsive medical patient. Medical patient assessment consists of 4 main components: your skill in assessing a scene for relevant clues, your ability to conduct a good patient interview, your ability to identify key signs and symptoms, and your skill in performing body systems assessments. Depending on the dispatch information you are given regarding the nature of the illness, you will begin anticipating your patient's condition and needs. However, do not limit your thinking to chief complaint. Look carefully at all of your findings during the assessment.
We also address any life threats and level of consciousness, airway, breathing, circulation, skin color, temperature, condition. We move into the focused history and physical exam, where we really start to ascertain the information about the situation.
I've asked our paramedic to check you out a little further. He'll be here in just a moment.
With a responsive patient, the most valuable information will come from the patient. Gather as much information from them as soon as possible, in case they become unresponsive. This interview starts with the mnemonic SAMPLE for a complete history. The S is for signs and symptoms. Look for physical signs or medical conditions. Ask about symptoms, conditions that can't be observed but are described by the patient. A for allergies. Does the patient have any to food, medication, or environmental agents? M, medications. Have they taken any or do they take any prescription, non-prescription, or illegal substances? P, pertinent past history. Are there any underlying medical problems, diseases, or past surgeries or trauma? L, Last oral intake. When and what was the last thing they ate or drank? E. Events. What occurred before the patient became ill or had the accident? Did they experience any unusual symptoms or feelings? With a responsive medical patient, you can continue with a series of questions based on the patient's chief complaint using the OPQRST acronym. Your questions will reveal more specific clues. First, the onset. When and how did the symptoms begin? Provocation and palliation. What makes the symptom worse or better? Quality. How would you describe the pain? Radiation. Where is the pain and where does it go? Severity. How bad is the pain on a scale of 1 to 10? And time. How long have you had the symptoms?
Key points again are the patient's presentation, signs and symptoms, and knowing what makes up the different differential diagnoses for the various medical situations that may occur. And again, our goal is to not simply just pigeonhole a patient into a specific category to start, but look at it from a broad perspective. All the patients we start to work on medically usually start off with a general assessment. When needed, oxygen is provided. As appropriate, EKGs are run. As appropriate as well, then, as we determine the information about the patient, the interventions that seem to make sense would take place.
A focused physical exam or secondary assessment comes after this history taking. First, investigate the problems identified during the primary assessment and history. Evaluate the skin color, pulse, and blood pressure. Observe the rate and depth of respirations. Look for signs of trauma. Palpate the areas of concern and identify tender spots. Monitor the level of consciousness and orientation. If the patient's signs and symptoms are not specific enough, or if they are unconscious, confused, or unable to relay their chief complaint, you should perform a complete head-to-toe rapid medical assessment following the DCAP BTLS acronym. With this assessment, you can quickly identify any existing or potentially life-threatening conditions. Starting at the head and ending at the toes, carefully check for any deformities, contusions, abrasions, punctures or penetrations, burns, tenderness, laceration, or swelling.
Vitally important for us to be able to make an appropriate differential in the diagnosis in the field setting for these patients. We don't want to err on the side of inappropriately providing the wrong medication or the wrong care for them. So we've got to really make sure in the assessment process, particularly we usually find this in the focused history and physical exam, sometimes the detailed physical exam, but in the focused history and physical exam, more often than not, we have enough information there to make an informed decision about what's the appropriate care we would provide for those patients presenting to us.
Assess and document baseline vital signs. Monitor for trends or changes. This can provide useful information about the overall function of the patient's body. Also, check the capillary refill, pupil size, and reactivity.
At its essence, a BLS assessment or an ALS assessment are one and the same. EMTs need to gather the same amount of information as a paramedic. Paramedics or intermediates have to gather a little bit more, perhaps because they're going to do some intervention at a higher level. But even EMT basics have to be able to make a decision about whether they're going to use a patient's epi-auto injector to assist them with their nitroglycerin or to assist them with a respiratory ventilator. So when we look at the assessment levels between those two, it's of utmost importance that all EMS providers out there do a thorough assessment of their patients, gather as much as they can, and provide the appropriate care based on their findings.
For a patient whose condition is not critical, prepare them for transport following the focused history. If their condition is critical, your partner should begin preparing for transport while you are completing the assessment. During transport, reassess the airway, breathing, and pulse. For a critical patient, take vital signs every 5 minutes. If their condition is not critical, every 15 minutes. A detailed physical exam is a more in-depth exam that builds on the focused physical. It is usually performed en route and is helpful if you cannot readily identify a patient's problem or if you are seeking more information. However, most patients will have isolated problems, making the exam irrelevant or unnecessary.
Don't lose sight of why you're doing the assessment. The important thing to know is that you're doing that in order to be the detective and determine how you're going to provide future care. And so what you've really got to do is be able to just sit down all the time, systematically approach all the patients always the same way, don't deviate, and be able to take off to the right branch and ask the right information regarding the specific situation, bring that branch back together, and close out with providing all the appropriate care that would be in place for a pre-hospital care situation.
You are not required to diagnose a medical condition or disease, but it is important to recognize significant signs and symptoms. Consult with your medical director for specific direction or follow your local protocols for treatment modalities when necessary. You will be relying on information from the patient, their signs and symptoms, and your findings during the focused exam. The treatments you provide for any life-threatening conditions will be based on your careful assessment.